Most people glance at their feet quickly, maybe towel off after a shower and move on. But if you have noticed that one or more of your toenails have turned yellow, thickened, maybe crumbling a little at the edge, perhaps lifted slightly from the nail bed, your first instinct is probably to reach for an antifungal treatment. The pharmacies are full of them. And the cultural assumption is so strong that yellow toenails mean fungus that most people never stop to consider that the nail is doing something far more interesting than harboring a dermatophyte infection. It is, in many cases, communicating. Your nail is a metabolic readout, a slow-growing keratin structure that takes approximately 12 to 18 months to fully replace itself, meaning that every millimeter of it carries a record of what was happening in your internal environment months ago. Yellow discoloration that is not fungal is not a cosmetic nuisance. It is a clinical signal that deserves a systematic investigation. I want to be precise about something before we go further. I am not telling you that antifungal cream is always wrong. Onychomycosis, the medical term for nail fungal infection, usually caused by Trichophyton rubrum, is the most common nail disorder in adults over 60, affecting approximately 10% of the general population, according to data published in the Journal of the American Academy of Dermatology. If the discoloration is fungal, treatment is appropriate. What I am saying is that the clinical workup should not stop at the visual assumption, because the conditions that produce yellow toenails that look exactly like fungus but are not include some of the most important and treatable systemic pathologies in medicine. Missing them costs people years. If this is the kind of clinical precision you are looking for, the kind that looks past the surface level answer and asks what the body is actually saying, then subscribe, hit the bell. I am building a channel for people who want their health information at the level of mechanism, not surface level symptom management. Let me tell you about the patient who made this personal for me. He was 58 years old. He had been treating his yellow, thickened toenails with over-the-counter antifungal products for 3 years. No improvement. He had also seen a podiatrist who prescribed topical cyclopyrox, a prescription antifungal, and after 6 months of use, the nails looked exactly the same. He mentioned it during an appointment that was ostensibly about his blood pressure, almost as an aside. When I looked more carefully, the pattern of discoloration was bilateral and symmetric, involving all 10 toenails, with a diffuse yellow hue rather than the focal discoloration from the nail edge that is characteristic of fungal infection. His nails were smooth, not crumbling. There was no debris under the free edge. A nail clipping sent to the lab, which is the definitive test for fungal infection, came back negative. What he had was a combination of peripheral vascular disease, severely limiting blood flow to his distal extremities, combined with early lymphedema that was affecting the protein composition of the interstitial fluid bathing the nail matrix. His nails were not infected. They were ischemic and edematous. And the correct response was not more antifungal cream. It was a vascular evaluation, compression therapy, and aggressive cardiovascular risk factor modification. Here is the biology. The nail matrix, the living tissue at the base of your nail, hidden under the skin behind the cuticle, generates the keratin cells that become the nail plate. This process requires adequate blood supply, adequate oxygenation, adequate delivery of nutrients including zinc, biotin, protein, and sulfur-containing amino acids, and proper lymphatic drainage to remove the metabolic waste products of keratin synthesis. When any of these inputs is disrupted, the quality and color of the keratin that is produced changes. Think of the nail matrix as a factory with a very long production line. The product coming off the end of the line reflects conditions at the start of the line up to 18 months ago. Yellow, thickened, slow-growing nail, the factory has been running under suboptimal conditions for a long time. Now let us go through the real causes of yellow toenails that are not fungal systematically. Cause 1. Peripheral vascular disease and arterial insufficiency. When the blood supply to the feet is compromised by atherosclerosis, the buildup of plaque in the peripheral arteries, the nail matrix receives less oxygen and fewer nutrients. The keratin it produces is abnormal. The nails grow more slowly, thicken, and develop a yellow to brownish yellow hue. This is not cosmetic. Peripheral artery disease is a powerful marker of systemic atherosclerotic burden. Research published in the Journal of the American College of Cardiology has established that PAD carries a comparable cardiovascular mortality risk to a history of heart attack or stroke. Other clinical signs of PAD in the feet that accompany the nail changes include loss of foot hair, skin that is shiny and atrophic, pallor when the foot is elevated, and dependent rubor when it is lowered, and cool skin temperature. The ankle brachial index, a simple, non-invasive blood pressure ratio test comparing ankle and arm pressures, is the standard screening test and should be part of every workup for unexplained nail changes in patients over 50. Cause 2. Yellow nail syndrome. This is rare but important to know exists. Yellow nail syndrome is a triad of yellow nails, lymphedema, and pleural effusions fluid around the lungs, though not all three features need to be present simultaneously for the diagnosis. The underlying mechanism involves impaired lymphatic drainage affecting the nail bed, which causes protein-rich fluid to accumulate in the tissue surrounding the nail matrix, altering the optical properties of the nail plate and producing the characteristic yellow color. It has been associated with thyroid disease, immune dysfunction, and in some cases malignancy, though many cases are idiopathic. The nails in yellow nail syndrome are typically very slow-growing, curved transversely in a hump shape, and lack a cuticle. This combination is clinically distinguishable from fungal infection, though it often goes unrecognized. Research documenting its associations is largely case series and observational. This is Tier 2 to Tier 3 territory, but its recognition matters because the systemic associations warrant investigation. Cause 3. Lymphedema. As with yellow nail syndrome, impaired lymphatic drainage from any cause, chronic venous insufficiency, post-surgical lymph node removal, obesity, or primary lymphatic dysfunction can alter the interstitial fluid composition surrounding the nail matrix and produce yellow nail discoloration. Bilateral lower extremity lymphedema producing yellow toenail changes is something I see with enough regularity in clinical practice to list it as a Tier 3 clinical observation. The accompanying signs, pitting or non-pitting edema of the feet and ankles, a positive stemmer sign, not ability to pinch a fold of skin at the base of the second toe, make the diagnosis clinically apparent. Cause 4. Thyroid dysfunction. Both hypothyroidism and, less commonly, hyperthyroidism can produce nail changes. In hypothyroidism, slowed metabolic rate affects every rapidly dividing cell type in the body, including the nail matrix cells. The nails grow slowly, thicken, become brittle, and take on a yellowish hue. The nail changes of hypothyroidism are accompanied by other classical signs: dry skin, hair thinning, particularly at the outer third of the eyebrow, fatigue, constipation, cold intolerance, and weight gain. Research published in the Indian Journal of Dermatology has documented nail changes in thyroid disease, though the evidence is primarily descriptive and observational. The critical clinical implication is that if your toenails are changing color and you also have unexplained fatigue, cold sensitivity, and constipation, a full thyroid panel is a higher priority test than a nail culture. Cause 5. Diabetes and glycation. Elevated blood glucose over time drives a process called glycation, the non-enzymatic binding of glucose molecules to proteins, including the keratin proteins of the nail plate. This chemically alters the structural proteins of the nail and produces discoloration, thickening, and brittleness. Research from the Journal of Investigative Dermatology has shown that advanced glycation end products accumulate in the nail keratin of diabetic patients, and that the degree of nail discoloration correlates with HbA1c, the standard marker of long-term blood glucose control. This is clinically relevant because diabetic patients are also at higher risk for onychomycosis, meaning that in a diabetic patient with yellow nails, there may be both glycation and infection present simultaneously, and both deserve attention. Foot care in diabetes is a specific clinical priority because of the combination of peripheral neuropathy, vascular compromise, and immune impairment that creates risk for wound infection and ultimately amputation, I want to stop here and ask you to drop your age in the comments below. Here is why the number matters. Under 40. Yellow toenails are uncommon enough that when they occur, a systemic investigation is warranted promptly. The prior probability of a benign explanation is lower. Between 40 and 60, the differential shifts toward metabolic and vascular causes, and a metabolic panel, including fasting, glucose, HbA1c, thyroid function, and lipids, is the priority workup alongside the nail culture. Over 60, the cumulative probability of onychomycosis genuinely increases, but so does peripheral vascular disease, making this an age group where both must be actively evaluated rather than one assumed and the other dismissed. Your age shapes the clinical sequence. Cause 6. Nutritional deficiencies. The nail matrix is a high turnover tissue, and it is sensitive to nutritional adequacy. Zinc deficiency, one of the most common nutritional deficiencies globally, affecting an estimated 2 billion people, according to the World Health Organization, produces characteristic nail changes, including white spots, lines, and a general dullness or discoloration. Zinc is required for the metalloenzymes involved in keratin synthesis and for normal immune function in the skin and nail unit. Biotin deficiency produces brittle, fragile nails. Though the evidence for biotin supplementation improving nail quality in non-deficient individuals is weak, this is an important distinction that the supplement industry glosses over. Protein malnutrition, clinically relevant in older adults with poor appetite, in individuals recovering from illness, or in restrictive dietary patterns, affects nail quality directly because keratin is a protein. A yellowish, dull, slow-growing nail in a patient with clear undernutrition is a nutritional signal, not a fungal one. Cause 7. Medication effects. Multiple medications produce nail discoloration as a side effect. Tetracycline antibiotics used for acne and respiratory infections can produce photoonycholysis, a separation of the nail from the nail bed triggered by sun exposure, along with yellow-brown discoloration. Antimalarials, including hydroxychloroquine and chloroquine, can cause yellow to blue-gray nail discoloration through melanin-related mechanisms. Certain chemotherapy agents, including taxanes and bleomycin, produce nail changes as a side effect. If your yellow nails began or worsened after starting a new medication, the medication history is a crucial diagnostic clue. Here is the actionable protocol, what to actually do when you notice yellow toenails. Step 1. Get a nail clipping cultured for fungus before treating. This is the standard of care, and it is ignored most of the time. A nail clipping or nail plate biopsy sent to a dermatopathology laboratory for both KOH preparation and culture is the definitive test for onychomycosis. Empirical antifungal treatment without diagnostic confirmation means potentially treating a non-fungal condition with a months-long course of medication that carries its own side effect profile, including hepatotoxicity, with oral terbinafine for a problem that was never fungal. Step 2. Request the metabolic workup. Fasting glucose and HbA1. C for glycation and diabetes. TSH and free T3 for thyroid function. A full lipid panel, and if over 50, an ankle brachial index for peripheral vascular disease. Zinc and iron levels. A basic metabolic panel assessing kidney and liver function. This is the minimum workup for yellow toenails without a confirmed fungal diagnosis. Step 3. Address what you find. If it is metabolic optimizing blood glucose control through dietary change and appropriate medical management directly improves nail quality over time, as reflected in research correlating HbA1c improvement with nail changes in diabetic patients. If it is thyroid, treating hypothyroidism normalizes nail growth rate and appearance within 6 to 12 months. If it is vascular, the same cardiovascular risk factor modifications I describe in other contexts apply. Blood pressure control, statin therapy if indicated, smoking cessation, exercise, dietary modification. If it is nutritional targeted repletion of zinc, protein, and specific vitamins produces measurable nail quality improvement within the nail's regeneration timeline of 12 to 18 months. Your nails are not decorative. They are a metabolic record. When they change, the question to ask is not just what will make them look better, but what is the body telling me about what is happening below the surface? That question, pursued systematically, sometimes leads to a diagnosis that genuinely changes the trajectory of your health. Your health is your responsibility, not the pharmacy's. I'll see you in the next video. Let me go deeper on the fungal versus non-fungal clinical distinction, because this is where the diagnostic process most commonly breaks down. And I want to give you the specific pattern recognition tools that clinicians use at the bedside. Onychomycosis true fungal nail infection has a characteristic presentation that differs in important ways from the systemic conditions I have described. Fungal infection almost always begins at the free edge of the nail, the far end, or at the lateral edges and progresses proximally toward the cuticle. It produces subungual debris, a white to yellowish, crumbly, powdery material under the leading edge of the nail. The nail plate itself becomes thickened and friable, meaning it crumbles or chips easily. The infection is often asymmetric in early stages, affecting 1 or 2 toenails while others are spared. And in classic onychomycosis, the great toenail is most frequently involved first because it sustains the most mechanical trauma and the greatest pressure from footwear. When I see yellow toenails that begin at the far edge that produce visible debris when the nail is trimmed, that affect the hallux first, and that are present in a patient who uses communal changing facilities or walks barefoot in public spaces, that is a fungal presentation. When I see yellow discoloration that is uniform across the entire nail plate, symmetric across multiple toenails, with no subungual debris, no crumbling, slow nail growth, and accompanied by systemic symptoms, that is a systemic signal, the distinction matters profoundly because the treatment protocols diverge completely. For confirmed fungal infection, oral terbinafine, taken daily for 6 weeks for fingernails and 12 weeks for toenails, has the highest cure rates of any available treatment, with studies published in the Journal of the American Academy of Dermatology reporting mycological cure rates of approximately 70%. Topical agents including efinaconazole and tavabarol have modest evidence for mild to moderate cases and are preferable for patients who cannot take systemic treatment. Laser treatments for nail fungus have a variable evidence base. Multiple devices have been studied with inconsistent results. In a 2020 systematic review in the Journal of Dermatological Treatment concluded that the evidence was insufficient to recommend laser as a primary treatment. This is genuinely Tier 2 territory, and the price points for laser treatments should be weighed against the evidence quality. For non-fungal yellow nails, by contrast, antifungal treatment does nothing not because it is the wrong drug, but because there is no pathogen to treat. The only thing that improves the appearance and health of the nail in these cases is addressing the underlying systemic cause, allowing the nail matrix to resume producing healthy keratin, and waiting the 12 to 18 months it takes for the new nail to fully grow out. I also want to speak to the role of local nail care in supporting recovery regardless of cause. Proper nail trimming straight across, not curved into the corners, with a clean file to smooth the edges, prevents mechanical trauma to an already compromised nail unit. Keeping the feet dry and the nails dry, particularly in the space between toes where moisture accumulates, reduces the secondary risk of fungal superinfection even when the primary cause is systemic. Nail moisturization using a urea-based cream applied to the nail plate and surrounding skin is supported by research showing that urea improves nail hydration and reduces thickening and brittleness regardless of underlying cause. A 10 to 40% urea cream applied nightly under occlusion is a simple, inexpensive intervention that genuinely improves the mechanical quality of dystrophic nails while you address the root cause. There is one more cause I want to address, specifically smoking. Nicotine and the other compounds in tobacco smoke cause direct vasoconstriction of the peripheral microvasculature, the tiny capillaries that supply the nail matrix. Chronic smokers have measurably reduced nail fold capillaroscopy readings, meaning the density and function of the capillaries feeding their nails is genuinely impaired. The nails of long-term smokers develop the same kind of ischemic yellow discoloration as patients with peripheral artery disease because the mechanism is similar: reduced oxygen delivery to the nail matrix. This is direct Tier 1 physiology. If you smoke and your nails are yellow, the tobacco is a direct causative factor, not merely an association. Cessation allows gradual restoration of peripheral microvascular flow, and nail quality typically begins to improve within 6 to 12 months of sustained abstinence. The practical question I hear most often is this: my nails have been yellow for years, I have treated for fungus multiple times with no improvement, and now I am worried about what else is going on. What do I actually do? The answer is to approach it the way any good clinical workup should proceed, from the most dangerous potential cause toward the most benign. Rule out vascular disease. Rule out diabetes. Rule out thyroid dysfunction. Rule out significant nutritional deficiencies. If all of those workups are negative, then the conversation turns to either an adequate trial of confirmed diagnosis antifungal therapy, or in cases where the nail changes are cosmetically distressing but clinically benign, nail cosmesis and supportive care. While you optimize the systemic inputs I have described, the nail will tell you over time whether the interventions are working. It is a slow feedback loop, 12 to 18 months, but it is honest. One final clinical pearl. The nail fold the skin directly around the nail at the base carries its own diagnostic information. Tiny dilated capillaries visible in the nail fold, detectable with a magnifying glass or dermatoscope, suggest connective tissue diseases including lupus and scleroderma. Ragged, frayed cuticles are associated with the same conditions. Darkened longitudinal streaks, melanonychia, require evaluation for melanoma. White transverse lines, Mies lines, have classically been associated with arsenic poisoning and are now associated with any severe systemic illness that temporarily disrupts nail growth. Half and half nails proximal white with distal brown are associated with renal failure. The nail is genuinely a window to systemic health, and learning to read it is a clinical skill worth developing. Your toenails are not just a cosmetic concern and not just a fungal habitat. They are a slow-moving readout of your vascular health, your metabolic function, your nutritional status, and your inflammatory environment printed in keratin 12 to 18 months at a time. Read them carefully. There is something I want to address that sits at the intersection of the diagnostic picture and the daily lived experience of having problematic toenails, and that is the psychological dimension. It sounds minor, but it is not. Patients who have struggled with discolored, thickened, or disfigured toenails for years frequently develop avoidance behaviors. They stop wearing open-toed shoes. They avoid swimming pools and changing rooms. They feel embarrassed during medical appointments and delay foot examinations. This avoidance creates a compounding problem. The feet get inspected less frequently by both patient and clinician, meaning that early warning signs of more serious pathology, pre-ulcerative skin changes, early Charcot foot deformity in diabetics, the subtle warmth and swelling of early cellulitis are caught later than they should be. Research from the American Podiatric Medical Association has documented that patients with nail conditions report significant quality of life impairment, and that shame and embarrassment around foot appearance is associated with delayed care seeking. If you have been avoiding looking at your feet or avoiding your doctor's examination because of nail appearance, I want to name that dynamic explicitly. Your feet need to be examined regularly, particularly if you have diabetes, peripheral vascular disease, or any systemic condition that compromises lower extremity blood flow. The nail discoloration that embarrasses you may be the least important thing being missed. The other practical reality worth addressing is the timeline of improvement and how to manage expectations honestly. If your yellow nails are systemic in origin, driven by metabolic, vascular, thyroid, or nutritional causes, you need to understand that the nails will not return to normal appearance immediately after the underlying cause is addressed. The nail matrix produces approximately 3 millimeters of nail per month on average, slightly less in the toenails than the fingernails, and significantly slower in the setting of poor vascular supply. A 12-month commitment to the underlying systemic intervention before evaluating nail appearance is a realistic timeline. 6 months in, you may begin to see a healthier looking band of nail growing from the proximal end from the cuticle outward, while the distal damaged portion is still present. This is a good sign. It is the matrix producing improved keratin as the systemic environment improves. Photograph your nails monthly with consistent lighting and angle to objectively track this progress, because subjective day-to-day assessment is unreliable. The integration of nail health into a holistic assessment of your systemic health is not something most annual physicals accomplish. Most physical exams do not include a careful nail inspection. This is an area where your own observation and attention genuinely compensates for a gap in routine clinical practice. Learn what your nails look like when you are well. Notice when they change. Ask the right questions when they do. The clinical answers are available. They just require someone to look carefully and ask what the body is trying to communicate.